Welcome to the deep dive. Today, we're looking at the world of equine athletes. Just think about their power, their grace. It's incredible.
Truly breathtaking. Elite athletes, really.
But that level of performance brings unique physical challenges. And today, our focus is on one of the most common and honestly often frustrating ones, equine suspensory ligament desmitis, ESLD.
Right. Most people probably know it simply as a suspensory injury.
Exactly. And it's a big deal.
Oh, absolutely. It's a leading cause of lameness. We're talking, roughly 30% of performance horses across all sorts of disciplines, dressage, jumping, eventing.
Wow, 30%.
Yeah. And these injuries, they don't just mean pain and lameness for the horse. They often lead to really long layoffs, expensive treatments.
Yeah.
It has significant economic impact, too.
So our mission for this deep dive is to unpack ESLD. We want to draw out the key insights from the sources we've looked at and give you a clear, comprehensive understanding.
Which is good.
To really get why these injuries are so debilitating, we need to start with the basics. So, okay, let's unpack this. What exactly is the suspensory ligament?
Well, think of it as the horse's ultimate shock absorber and a spring, really.
A spring, okay.
Yeah, it's this incredibly complex fibrous structure. Sometimes it's even called the interosseous muscle, which is interesting. It's absolutely crucial for the biomechanics of the horse's leg.
And where is it located?
It starts high up on the back of the cannon bone, that long bone between the knee or hock and the fetlock.
Right.
Then it runs downwards and splits into two strong branches. These branches basically cradle and support the fetlock joint, the horse's ankle, you could say.
So it's holding things together, but you said it's also a spring, not just passive support.
Exactly. It's not just a passive strap. Its main job, yes, is to robustly brace that fetlock joint, stop it sinking too far down during peak weight bearing. It absorbs immense stress.
Okay.
But the really amazing part is its elastic band function. It literally stores kinetic energy as the foot loads, and then releases that energy to help propel the horse forward. That elastic recoil is just vital for athletic performance. Gives them that power and efficiency.
That makes so much more sense than just thinking of it as a rope. It's dynamic.
Very dynamic.
Are there any subtle differences, like between the front and back legs?
There are, yeah. In the hind limb, for instance, its origin point is a bit less distinct, kind of bilobed, and the ligament itself tends to be more oval-shaped in cross-section, positioned slightly to the outside.
And that matters for injuries.
It does. These small anatomical differences actually influence where injuries tend to happen and, importantly, how we interpret things like ultrasound images.
Okay. And what about this idea I read about that it has a muscular component? That sounds really odd for a ligament.
It's fascinating, isn't it? It's considered an evolutionary leftover, basically, a derivative of the interosseous medius muscle.
So it has actual muscle fibers.
Yes, it retains some muscle fibers, particularly in its upper proximal portion, which implies it's not entirely passive. There's a dynamic, maybe even slightly contractile element there.
Huh. Does that change how you approach rehab?
It potentially could.
Yeah.
It suggests that rehab shouldn't just focus on the ligament tissue itself, but maybe incorporate muscle-specific therapies too. Strengthening exercises, perhaps electrotherapy. It pushes towards a more holistic view of healing.
So it's clearly this marvel of equine engineering, built for power, built for resilience.
Absolutely.
Which brings us back to the main question. If it's so sophisticated, why are these injuries so incredibly common? What's going wrong?
That's the million-dollar question, isn't it?
Huh.
Injuries can happen from a single acute event, a bad step, a fall,
Or a sudden trauma.
But honestly, much more often what we see is damage from chronic repetitive strain.
Like wear and tear.
Exactly. Think about high-intensity jobs, racing, jumping, eventing, the constant pounding, the extreme forces. It leads to accumulated microdamage over time.
Little bits of damage adding up?
Right. And if the horse's natural repair processes can't keep up, the integrity of the bone and the ligament itself gets compromised. That's how you can end up with things like stress fractures, which often go hand in hand with or even precede the ligament injury itself.
Does the horse's actual build, its conformation, play into that? Are some horses just set up for this?
Oh, absolutely. Body mechanics are huge. Certain conformational issues definitely increase susceptibility.
Like what?
Well, for example, horses with really straight hocks and stifles in the hind limbs. They often develop weak fetlocks that hyperextend, putting extra stress right on the suspensory apparatus.
I see.
And hoof balance is critical too. Things like long toes, low heels, they change the forces and increase strain. Even subtle things, like being a bit toed in or toed out, can concentrate stress unevenly.
What about the front legs?
in the forelimbs, being over at the knee can contribute. And we particularly worry about horses whose fetlocks look hyperextended even when they're just standing still. They tend to be more vulnerable, and often the prognosis isn't as good if they do get injured.
So conformation matters. What about how they're trained? The workload?
Critical. Absolutely critical. High work levels, intense exercise, they significantly raise the risk. Fatigue is a factor too, especially in speed events.
Yeah, so?
When a horse gets tired, their gait can change, how they move their limbs alters, and that can make them more susceptible to a bad step or uneven loading.
Makes sense.
Even in disciplines like dressage, those repetitive movements, well, maybe not high impact, can cause microscopic tears from chronic, ongoing stress.
Mm.
And specifically for stress fractures, which, as I said, often link to suspensory problems, certain training patterns are risky, like not building up gallop speeds properly, doing too much cumulative distance work, or coming back too quickly after a rest period.
So it's not just the horse, it's the training, the conformation. What about where they work, the ground?
Hugely important. Environmental factors, especially the footing surface, it's paramount.
Too hard, too soft.
Both can be problems. Very hard ground increases concussion, obviously, but excessively soft or unstable ground can cause the hoof to slide or twist unexpectedly, inducing weird limb movements and stressing the ligaments.
Any examples?
Yeah, there have been studies linking, say, sand gallops in the UK to more distal limb fractures. And in North America, dirt racing surfaces are often associated with higher injury rates compared to turf. It just shows how all these factors, the horse, the training, the environment, are interconnected.
Are certain ages or breeds more susceptible?
Well, we see suspensory injuries a lot in younger athletic horses, maybe 2 to 4 years old as they're starting intense work. But older horses certainly get them too.
Okay.
But it's really important here to distinguish these typical suspensory injuries from a condition called degenerative suspensory ligament disease, or DSLD.
DSLD. Okay. Different thing entirely.
Yes. You might also hear it called ESPA, equine systemic proteoglycan accumulation. This is a progressive systemic disorder affecting connective tissue. And the current thinking is that it's likely genetic.
That sounds really different and potentially much worse. What sets DSLD apart?
What's really characteristic is that DSLD often affects multiple limbs. So maybe both front legs or both hind legs, or sometimes even all four.
Wow.
And the onset is usually subtle, gradual. There's often no clear history of a specific injury event. It just sort of develops.
Which breeds are affected?
It's seen in quite a few breeds, most commonly associated with the Peruvian Paso, but also Paso Finos, warmbloods, thoroughbreds, standardbreds, quarter horses, Arabians, saddlebreds. It's pretty widespread.
And what does it look like clinically?
The classic sign is that progressive dropped fetlock coherence. The fetlock joints gradually sink lower towards the ground. You might also see heat and swelling around the fetlocks.
And lameness.
Yes, often stumbling, a shifting lameness that might move between legs. Sometimes compensatory back soreness develops, and their gait can change. They might land toe first, move with stiff legs, or even show a kind of bunny hopping gait in the hind end.
So it's not just a local ligament problem, it's body-wide.
Exactly. That's the key. The underlying issue in DSLD is an abnormal accumulation of proteoglycans. These are molecules that normally help build connective tissue. But in DSLD, they build up incorrectly, and paradoxically, this weakens the ligaments and tendons instead of strengthening them.
Wow. So it's a biochemical problem.
Fundamentally, yes. A systemic biochemical issue that then gets made worse by the normal biomechanical stresses of movement and weight bearing.
Which means treatment must be different too.
It has to be. Management for DSLD often goes beyond just physical therapies. It frequently involves specific nutritional changes, like low sugar, low starch diets, maybe supplementing with omega-3s. And dynamic fetlock supporting devices can be really crucial to provide external support.
Okay, that distinction is vital. Going back to the more standard suspensory injuries, you mentioned they can be hidden early on.
Yes, that's a significant challenge. Lameness isn't always obvious or consistent, even when there's moderate or even severe damage on imaging.
Why is that?
Sometimes the injury develops gradually. Or if both limbs are affected, the horse might not show a clear head nod lameness, just maybe reduced performance or reluctance to work.
And you mentioned stress fractures being linked.
Right. And diagnosing those early stress fractures is absolutely critical. Because if they're missed and the horse keeps working, they can progress to complete catastrophic fractures, which is career-ending, sometimes life-ending.
So finding these subtle issues early is key.
It is. and it often means we need to reach for advanced diagnostic imaging, even if the outward signs are mild.
Which makes diagnosis sound like, well, like a real detective story for the vets. How do you find something that can be so subtle?
It really can be detective work. The clinical signs vary so much depending on where the injury is and how bad it is.
So lameness might not be obvious.
Sometimes it's very subtle, maybe only noticeable on soft ground, or when the horse is lunged in a circle with a sore leg on the outside. Or, as I said, if both front or both hind legs are involved, you might just see a general loss of impulsion, maybe poor performance, rather than a distinct limp.
And hind limb ones can be tricky.
Yes, hind limb suspensory issues can sometimes look like other problems owners might report a weakness behind, or maybe the horse seems stiff initially but warms out of it with exercise. You might also notice specific gait changes, like a shorter forward swing of the leg.
What about physical signs? Things you can feel or see?
During the exam, we're looking for any localized heat, swelling, or signs of pain when we press on the area. If it's a branch injury, lower down, you can often feel a thickening of the ligament branch itself.
Uh-huh.
Sometimes you'll see fluid buildup, effusion in the nearby fetlock joint or the tendon sheath, those wingulls owners often notice. And applying pressure, deep palpation, or flexing the fetlock joint will usually make the horse react if there's pain.
And in really bad cases?
In severe cases, like a rupture, you'll see that obvious fetlock drop. And often, they'll develop secondary back soreness from compensating.
So you see some signs, you do the physical exam. What's the next step to really pinpoint the source?
It's definitely a multi-pronged approach. We start with that thorough physical and lameness exam, looking at the horse, standing still, symmetry, muscle development, palpating everywhere, using hoof testers, doing flexion tests to see if we can make any lameness more obvious.
And watching them move.
Absolutely.
Yeah.
Walk, trot, in straight lines, on circles, ideally on both hard and soft surfaces. And this is really important for performance horses, examining them under saddle.
Why under saddle specifically?
Because sometimes the lameness only shows up, or gets significantly worse, when the horse has the rider's weight and is asked to do specific movements required by its job.
Okay, makes sense. Then what? Nerve blocks.
Nerve blocks are a cornerstone, yes. Diagnostic analgesia. We inject a small amount of local anesthetic very precisely around specific nerves to numb a particular area.
And if the lameness goes away,
Then we know the pain is coming from the area supplied by that nerve. It helps us localize the problem. It can be tricky with the suspensory, though, because it's deep.
right.
So it requires really accurate technique. We usually work systematically, blocking lower down the leg first to rule out foot pain, for instance, before moving up towards the suspensory region.
So once you've narrowed down the area with blocks, how do you confirm what the injury actually is? What kind of damage?
That's where imaging comes in. And we have several tools. Ultrasonography is usually the first step for soft tissues like ligaments.
So can you see on ultrasound?
It lets us look directly at the ligament fibers. We look for signs like the ligament being enlarged or its shape being distorted. We look at its echogenicity, that's how bright or dark it appears. Darker hypoechoic areas might mean fiber disruption or fluid. Brighter hyperechoic areas could be scar tissue or mineralization.
Can it show active inflammation?
Sometimes, yes. Using paradoppler ultrasound can detect increased blood flow, neovascularization, which suggests active inflammation or healing is happening. But ultrasound has limitations. Interpretation can be subjective sometimes.
Okay. What about x-rays?
Radiography, or X-rays, are crucial for checking the bones. Ruling out stress fractures, any bone spurs, called enthesophytes where the ligament attaches, or small avulsion fractures where a chip of bone is pulled off.
Can x-rays show the ligament damage itself?
Not directly, but for injuries high up, at the origin, proximal suspensory desmitis, or PSD X-rays, might show changes in the bone where the ligament attaches. Increased bone density, sclerosis, maybe some fuzzy new bone formation.
Is that definitive?
Not always. Mild changes can sometimes be normal. But one key finding that's considered more specific for PSD is a multifocal pattern of increased bone density. That's more likely to indicate pathology. But a big caution, X-rays can definitely miss early or subtle stress fractures.
So you might need something more sensitive, like a bone scan.
Exactly. Nuclear scintigraphy, the bone scan, is very sensitive to areas of active bone turnover or inflammation. It shows up as hotspots.
Good for stress fractures then.
Often the best choice for picking up early stress fractures, especially in tricky areas like the pelvis or vertebrae. It highlights that active bone reaction right where the ligament attaches. But its specificity isn't perfect, and the resolution isn't great.
Which brings us to MRI.
Which brings us to MRI. magnetic resonance imaging. And MRI is widely regarded as the gold standard for diagnosing suspensory ligament injuries, especially PPSD, those ones high up.
Why is it so much better?
Its soft tissue contrast is just exceptional. It gives incredibly detailed pictures of the ligament itself, inflammation, fiber tears, fluid, even early degenerative changes that ultrasound might miss.
And it shows bone, too.
Yes, it's great for picking up bone edema, that bruising within the bone that often accompanies these injuries. Plus, it images in multiple planes, giving a 3D perspective, and it can spot other concurrent problems in the joint or nearby tendons.
Is it practical, though? Doesn't the horse need anesthesia?
Traditionally, yes, but the availability of standing MRI units has been a game changer. It reduces the risks associated with general anesthesia, and MRI is actually more sensitive than even a bone scan for picking up those very early cortical stress fractures.
What about CT scans?
Computer tomography, or CT, gives fantastic 3D detail of bone, so it's excellent for complex fractures, microfractures, maybe planning a surgical repair, and there are standing CT options available now, too.
So it sounds like diagnosing these, especially the high ones, PSD, is really tough. Deep location, subtle signs.
It is. Often there's no obvious external heat or swelling. Lameness can be mild or confusing if it's bilateral. That's why those nerve blocks are so critical for localization. And then you really need the advanced imaging ultrasound, maybe scintigraphy, but ideally MRI, to confirm and fully assess the damage. It really takes that multimodal approach and experienced eyes.
Okay, so the detective work pays off. You got the diagnosis. What happens next? What does treatment look like?
Treatment really has to be multifaceted and tailored to the specific injury and the horse. But for many cases, especially if they're acute or not too severe, conservative management is where we start.
Which means rest.
Yes, initially. Usually strict stall confinement for maybe 2 to 4 weeks, just to let the initial inflammation settle down.
And then back to the field.
Not usually straight away. It's followed by a very gradual, structured, controlled exercise program, starting with hand walking, then slowly progressing to ridden walk, then trot, eventually canter.
Why so gradual?
The goal is to encourage the healing collagen fibers to align properly, making the scar tissue as strong and functional as possible. It's about remodeling the tissue correctly. But this takes time. Full healing often takes 9 to 12 months.
A long time.
It is. And rushing it is a big mistake. Returning to strenuous exercise too soon is probably the single biggest factor leading to re-injury or the injury just not healing properly.
What about for stress fractures? Same strict rest.
Actually, for stress fractures, controlled mobilization is often preferred over strict long rest. Gentle loading helps stimulate better bone remodeling.
Okay. And what about medications during this time? Pain relief?
Yes, anti-inflammatory drugs are important, especially early on. Systemic NSAIDs like phenylbutazone, Bute or Friocoxib, given orally or by injection, or topical creams like diclofenac.
Can you inject anti-inflammatories right at the site?
Sometimes for acute PSD, we might do paraligamentar injections of corticosteroids, meaning around, not in the ligament to reduce swelling and pressure on nerves. But there's a strong caution. Injecting corticosteroids directly into the ligament itself, especially if there's significant fiber damage, can actually harm the healing process.
Right. And then there are all the other therapies, lasers, shockwave, hydrotherapy. How do they fit in?
They're really valuable adjunctive therapies integrated into the rehab plan. Cold therapy, ice boots, cold hosing is great for reducing inflammation and pain, especially early on.
Hydrotherapy.
Hydrotherapy, like underwater treadmills, provides low-impact exercise, building strength without stressing the injury. Cold water spas offer cooling and massage effects.
And the others? Ultrasound, lasers.
Therapeutic ultrasound uses sound waves to gently heat deep tissues and stimulate healing. Electrotherapy like 10NS can help with pain relief, while PEMF uses electromagnetic fields to potentially stimulate healing at a cellular level. Laser therapy also has anti-inflammatory and potential healing benefits, and manual therapies like stretching help maintain flexibility.
What about shoeing? Does that play a role?
A huge role. Therapeutic shoeing is often essential because, as we discussed, foot balance issues can directly contribute to suspensory strain.
So corrective trimming?
Yes, careful corrective trimming and shoeing are designed to stabilize the hoof and reduce the forces acting on the suspensory ligament.
What kind of shoes?
Specific modifications might include things like egg bar shoes for heel support, or maybe shoes with a wider base at the toe to help reduce how far the fetlock drops. For hindlimb PSD, sometimes shortening the toe or using an extended heel shoe can help change the biomechanics favorably. The key is balancing the foot meticulously side to side, front to back, as this dramatically affects joint movement and soft tissue stress.
Okay. Now, what about the really cutting-edge stuff? Regenerative medicine.
Right. This is where treatments aim to enhance tissue regeneration, hopefully leading to stronger, more normal tissue rather than just scar tissue.
Like PRP.
Platelet-rich plasma, PRP is a common one. We take the horse's own blood, concentrate the platelets, which are packed with growth factors, and inject this concentrate into the injury site.
And the growth factors do what?
They stimulate new blood vessel formation, attract the body's own repair cells, including stem cells, and help modulate inflammation. Studies have shown it can improve lameness, lead to better tissue organization on ultrasound, and potentially improve return to competition rates compared to rest alone.
And actual stem cells.
Stem cell therapy is another major approach. We harvest mesenchymal stem cells, usually from the horse's bone marrow or fat tissue, culture them to increase their numbers, and then inject them into the lesion. The idea is they can differentiate into ligament cells, reduce inflammation, and promote better quality healing. Sometimes used alone, sometimes with PRP.
What about IRA?
IRA stands for interleukin-1 receptor antagonist protein. It's another therapy derived from the horse's blood. It produces a protein that blocks a key inflammatory molecule, interleukin-1. It's mostly used for joint inflammation, synovitis, or arthritis, so its direct benefit for ligament healing itself is maybe less established than PRP or stem cells.
And shockwave, ESWT.
Extracorporeal shockwave therapy, ESWT. This uses high-energy sound waves directed at the injury. It's non-invasive.
How does it help?
It's thought to stimulate blood flow, release growth factors, have a pain-relieving effect by temporarily blocking nerve signals, and help reorganize healing tissue. It can potentially accelerate healing and reduce layup time.
But you mentioned a downside.
Yes, the critical limitation is its analgesic effect, the pain relief. While helpful for comfort, it can mask the underlying injury. If a horse feels better due to shock wave, but the ligament isn't actually healed, returning them to work too soon is a big risk. Plus, there's a mandatory withdrawal time before competition.
That analgesic effect sounds tricky. Like you said earlier, pain relief can be a double-edged sword.
It absolutely can be. Managing pain is vital for welfare and enables controlled rehab. But therapies that only provide pain relief without fixing the underlying problem can be dangerous. They can mask how severe the injury really is.
Any examples?
Well, we'll talk more about bisphosphonates later, but they have analgesic effects alongside their bone effects. If a horse seems sound simply because the pain is blocked but the tissue hasn't healed structurally, putting them back into hard work can lead to catastrophic re-injury.
So you can't just rely on whether the horse looks sound.
Exactly. It really hammers home the need for objective measures of healing, follow-up ultrasounds, maybe MRI, to guide how quickly we progress through rehab. We need to know the tissue is actually repairing, not just that the pain is masked. It's crucial for preventing re-injury.
Are there challenges with these regenerative therapies? Like, do they always work?
That's a key point. There's still a lack of standardization, especially with things like PRP. Different studies use different preparation methods, different doses, different timing, so the results can vary quite a bit. It makes it hard to compare studies or know the absolute optimal way to use it. We definitely need more large-scale, well-controlled, standardized trials to really refine these therapies.
When does surgery become my option? Is it common?
Surgery is generally reserved for more severe injuries or cases where months of conservative management and maybe regenerative therapies just haven't worked.
What kind of procedures are done?
For hind limb PSD, a common procedure is a fasciotomy with plantar metatarsal neurectomy. The fasciotomy involves cutting the tight connective tissue band overlying the ligament to relieve pressure. The neurectomy involves cutting a specific nerve branch, the deep branch of the lateral plantar nerve, that primarily provides sensation to the ligament origin, aiming to eliminate chronic pain that might be causing lameness even if the ligament has healed structurally.
Does that work well?
Studies show pretty high success rates for return to previous levels of exercise with that combination for hind limb PSD, especially compared to conservative treatment alone for those chronic cases. Other surgical options might include desmoplasty, which is like surgically reinforcing the ligament, or ligament splitting, making small cuts to try and stimulate healing. And if there's an avulsion fracture, surgically removing the bone fragment might be needed.
So for those stubborn hind limb cases, surgery might offer the best shot.
For chronic hind limb PSD that hasn't responded to other treatments, that fasciotomy and neurectomy combination may well offer the best prognosis for getting the horse back to full athletic function.
So after all this rest, rehab, maybe therapies, or even surgery, what's the long-term picture? What's the prognosis, really? And how likely is re-injury?
The prognosis, the chance of getting back to full performance, it really depends on a lot of things. Where the injury is, how severe it was, the horse's age, whether it was an acute injury or a chronic problem, and if there were other issues going on at the same time.
Is front leg versus back leg a big factor?
Generally, yes. Forelimb suspensory injuries tend to have a better outlook, maybe around 80% resolution overall. Acute PSD in the forelimb treated conservatively, often a 90% success rate.
The hind limb.
Hind limb injuries have historically been much more challenging. With just rest alone, the success rate used to be quoted as less than 20%. Surgery, like we just discussed, definitely improves that, potentially up to 75 or 80%, maybe even higher according to some recent studies, but still generally tougher than forelimb injuries.
What about severity?
Makes sense, right? Mild or moderate injuries have a much better chance than severe tears. A horse with a really bad tear might become pasture sound, but rarely returns to high-level competition. Age is a factor too. Older horses just don't heal quite as effectively. And chronic injuries often need longer rehab, maybe more adjunctive therapies.
And concurrent injuries matter.
Definitely. If a horse has PSD and a stress fracture in the cannon bone right there, for example, that usually means a longer rehab and a higher risk of re-injury down the line.
You mentioned scar tissue earlier. Is that a big factor in prognosis?
A huge factor. Significant scar tissue formation, especially around the ligament paraligamentous fibrosis, is generally considered a negative prognostic indicator, particularly for hind limb injuries. If there's a lot of fibrosis, the return to full function rate might drop below 50%.
Why is scar tissue such a problem? Isn't it healed?
It's healed, but scar tissue simply isn't the same as the original ligament tissue. It lacks the elasticity, the stretchiness, and the overall strength. So the repaired area is inherently weaker and more prone to breaking down again under stress.
So sound doesn't always mean fully healed and strong.
Exactly. That's the critical discrepancy. A horse might look sound, might jog perfectly well, but the actual tissue healing, the restoration of strength, might not be complete. If you push them back into hard work too soon, based just on apparent soundness, the risk of re-injury is much, much higher. Again, it emphasizes why objective monitoring, like follow-up ultrasounds, is so vital.
What kind of recovery times are we generally looking at? Ballpark.
It varies hugely. A very mild strain might be 6 to 8 weeks of careful management, more severe tears. You could easily be looking at 8 to 12 months. Honestly, for most significant tendon or ligament injuries, you should probably budget 9 to 12 months for full healing and a safe return to full work.
And specific types.
For acute forelimb PSD treated conservatively, you'd hope to see a positive response within 3 to 6 months. Stress fractures depend on location, maybe 12 weeks for a tibia, perhaps 6 weeks before starting cantering for a pelvic fracture.
It's variable.
And unfortunately, suspensory injuries are notorious for recurrence. Re-injury is common.
Why? Just because of that scar tissue?
That's the main reason. The scar tissue just isn't as resilient. The risk is higher if the original injury involved a large core lesion, a big hole in the ligament. And, as I keep saying, returning to work too soon is a massive factor in recurrence.
Is a re-injury worse?
Generally, yes. Recurrent injuries, particularly PSD, tend to carry a worse prognosis than the initial injury. And horses with those underlying issues, like bad conformation or significant fibrosis from a previous injury, are definitely at higher risk.
Okay, so prevention seems absolutely critical if possible. What can owners and trainers actually do to try and avoid these injuries?
Prevention really needs a multifaceted, holistic approach. Because, as we've seen, so many factors play a role.
Like training.
Absolutely. Training adjustments and workload management are key. That means sensible, gradual conditioning programs, progressively building strength and flexibility, designing training to encourage good bone remodeling, maybe less long, slow work and more short bursts of higher intensity work, introduced carefully.
And being careful not to do too much too soon.
Exactly. Avoid rapid increases in intense work, like gallop or canter distances. Build in adequate rest and recovery periods. Individualize the program for each horse's needs and fitness level. And for stress fractures, remember controlled exercise is often better than total rest for healing.
What about surfaces?
Surface management is crucial. Ideally, train on a variety of good quality surfaces arena, maybe some road work, grass to build resilience. Avoid working consistently on excessively hard or deep, uneven ground. And be aware of known risks associated with certain track surfaces.
And conformation and shoeing.
Yes, regular conformation assessment to spot predispositions and meticulous corrective shoeing and hoof care. Addressing imbalances like long toes, low heels, or medial-lateral imbalance is vital to reduce strain. Using therapeutic shoeing principles, maybe egg bars, maybe adjusting breakover or heel support can make a big difference in how forces are distributed.
Does nutrition play a part?
Definitely. Nutritional support for healthy bones and soft tissues. A well-balanced diet with adequate energy, protein, vitamins, and minerals is the foundation. Things like calcium, phosphorus, magnesium, copper, zinc, vitamin A, D, K are all important. Some people also supplement with things like omega-3 fatty acids for anti-inflammatory effects, antioxidants, maybe silicon or collagen precursors.
Anything else? Management.
Yes, even turnout and social management. Allowing horses natural movement through appropriate turnout helps maintain tissue health and reduces stress. Keeping them in stable social groups minimizes fighting or running injuries. Introducing new horses gradually. Maintaining a consistent daily routine helps too. It's really about looking at the whole picture.
It sounds like a lot to juggle.
It is.
Right.
But because all these elements are interconnected, a comprehensive individual plan is really the best defense.
That's a really thorough overview of prevention. Now, thinking about treatments and prevention, is there anything particularly controversial or maybe misunderstood, something where the treatment itself might have downsides?
One area that generates a lot of discussion and concern is the use of bisphosphonates.
Okay, what are those used for normally?
They work mainly by slowing down bone resorption, the process where old bone is broken down. They inhibit the cells, called osteoclasts, that do this. They're officially approved for treating navicular syndrome in mature horses, usually over 4 years old.
So what's the controversy?
The concern is around their increasing use, often off-label, in young racehorses, sometimes under 2 years old.
Why is that a problem in young horses?
Because inhibiting that natural bone turnover process in a young, growing, exercising skeleton might actually be detrimental. It could reduce the bone's ability to adapt and remodel in response to the stresses of training. This might paradoxically make the bone stiffer and perhaps more prone to microcracks or stress fractures, not less.
And it could affect growth.
That's a major worry. Using them in very young animals could potentially interfere with normal physiological bone development, especially since osteoclasts play a crucial role in growth plates. Some equine surgeons have reported seeing abnormal erratic bone healing in horses that had received bisphosphonates when they were young. That's a significant red flag.
Are they easy to detect?
No, that's another issue. They stay in the bone for a very long time, months, even years, and they're difficult to test for.
So there are still questions about their effects.
Big questions. There's a critical knowledge gap about their long-term biological effects in young athletic horses. It really calls for more scientific research and very careful, judicious use, especially considering the potential welfare implications.
Wow. This deep dive has certainly shown just how complex equine suspensory ligament desmitis is. It's clearly a huge challenge in equine sports medicine.
It truly is. We've touched on the really intricate anatomy and how surprisingly vulnerable that ligament can be. We've seen the wide range of factors that can predispose a horse from their build to how they're trained, even the ground they work on.
And the difficulty in diagnosis.
Absolutely. The need for that multimodal approach,
Yeah.
using blocks, ultrasound, X-ray, and really MRI as the gold standard for getting the full picture of soft tissue damage.
Then the treatments.
A whole spectrum, right? From careful conservative management with rest and rehab, through regenerative options like PRP and stem cells, potentially to surgery for the tough cases.
And the crucial takeaway about healing.
Yes, the critical importance of assessing true tissue healing objectively, often with imaging, rather than just relying on apparent soundness. And of course, need for comprehensive, individualized prevention strategies in the first place.
It leaves me thinking, given how absolutely vital this ligament is for performance, and yet how difficult these injuries often are to heal completely, back to 100% original strength, what's next? What further innovations, maybe in diagnostics or perhaps in truly regenerative therapies that create new, healthy ligament tissue instead of just scar? What do you think could make the biggest difference in protecting the careers and welfare of these incredible equine athletes? Something for all of you to think about long after our deep dive wraps up.